All right. Oh, that would be good. Simple fixes, I like that. Yep, we're on. Okay. So, musculoskeletal, long session. Objectives, these guys are your guides. They're going to help you. Okay? Describe the pathophys, manifestations, complications, and collaborative care for clients with contusions, strains, sprains, fractures, amputations, and repetitive injury. Man, that's a mouthful. So it's a good idea to know what each one of those things are. Just saying. Explain the purposes and related nursing interventions for casts, traction, and stump care. We're going to cover it all. Explain the pathophys, manifestations, complications of degenerative and autoimmune inflammatory musculoskeletal disorders. You could take any one of these and make a whole course out of it. Describe the collaborative care and related nursing care of clients with musculoskeletal disorders. We're going to start out with contusions, sprains, and strains. Oh, please. I heard that yawn. Somebody needs some coffee?
I just finished a whole other extra shot.
All right, so looking at contusions.
Bruise.
That's it. That's all it is, a bruise, right? Versus a hematoma, right? Hematoma is a little bit bigger than just a bruise, right? Those nice big goosebumps that you get when you whack your head into a table, that you trip over your kid's toys, and then your kid gets a hematoma when he hits the table too, tripping, learning how to walk. Strains, those are those stretching of the injury to a muscle or a muscle tendon. It's caused by mechanical overloading. It can cause like little microscopic tears, and you can run into trouble with that long-term or chronic problems because those tears, they try to heal and they don't heal right, or it overstretches. And you think about does anybody remember Starling's law when you overstretch something? If you don't remember, go back and review it. Starling's law. You know, just when you overstretch something, it may not go back to its original shape, you know, and you can end up with, you know, chronic problems. You'll see here, you'll have these types of strains in the lower back and or the cervical region. You're going to have limited motion when you strain your back. Can you run a marathon very well? Not very easily, right? Swelling, spasms, sharp or dull pain. When you overstretch those muscles, they try to go back, so you end up with some muscle spasms. Sprains. That's an injury to a ligament that's surrounding a joint. You can overstretch or tear also. You got forces that are going in directions. That means opposite. You lose the ability to move or use the joint. Sometimes you'll hear it pop. You'll end up with discoloration, and that's usually with those micro vessels getting torn, and you get bleeding in that area. Think about your ankle sometimes. You get pain and rapid swelling. Very common in a knee or an ankle. I'm not talking about extreme that we sometimes see, but very rarely. We had a student, somebody had an issue last semester. But this is just a sprain, okay? And they'll say that sometimes a sprain can be worse than a fracture. Anybody ever hear that? These can be pretty darn painful. Yes, they do. There's a nice shot of a contusion. Nice old goose egg for a hematoma. That was probably more than just a coffee table. Maybe a baseball bat.
Just trying to absorb it back into the bottle.
Well, you're trying to make it. I think it's just
And if you can't remember from 101, look at the terms. Inversion, eversion. There's that foot. Shows you how you can sprain it. You can really tear those areas. Poor ligaments and tendons. So nursing care includes, think about RICE. It will help you out. It's an acronym. There's a few acronyms in this section. So, rest, ice, compression, elevation. Does everybody had a chance to see how you wrap a ACE wrap? Yep. Okay. Just an FYI, I suggest you pull out your lab manual, your student lab manual. Karen Stanfield and I went through a lot of work. Karen did a ton of pictures and hunting for those sites, and we have to update them every 7 weeks. Yay. But it gives you a lot of good information in there.
Isn't it just wrapping the bone below the sprain and above?
Yeah, but it's in a certain, you do it in a certain way. You have to do it kind of crisscross.
Right.
And there's a nice video on that. If you go into your lab manual, it shows you how to do that. You click on it and go to the site. I think there's some movies on it or something, but there's information on it. You want compression. You need support, but not too much. You don't want to cut off circulation, right? You got to do it in a certain way so that when you go around, can you see that ankle part right there? If it rolls around that area, it can tourniquet and cut off circulation, so you got to be really careful with that. Ice, at least, ice for the first 24 hours, you want to decrease the swelling, right? You have that inflammatory response going on, it's swelling. You don't want to end up having too much swelling. We'll talk about that a little bit later. So you want to decrease that. You don't want, you want blood to the area, but not too much. You want to decrease that swelling. You want to make sure you don't cut off your circulation. And then elevate to help, also help with that and decreasing that swelling. Usually you'll have immobilization for, that's why it says rest. When you see how he's got that elevated too, it's above the heart level. Where's his heart? Right about there, right? So rest and ice for about the first 24, 48 hours. You might have to get into physical therapy. Wow, that was so slow, it was almost backwards. Diagnosis and treatment. The first thing you want to do is, if they're checking that, they're going to do fairly minimally and cheap is an x-ray, because you want to rule out a fracture, right? Especially if you got a severe sprain. But x-rays, remember, are only going to show you bones, right? Doesn't give you much information on soft tissue. MRIs are kind of nice because it can give you more information on soft tissue injury, like a tendon or a ligament. A lot of people with rotator cuffs, they have to have MRIs so that they can see where that is torn. But it gives you more information on soft tissue. Where x-rays, CAT scan, if you think about CAT scan, bone and blood are usually the same color. But it doesn't, and for MRI, it's going to give you a lot more information on soft tissue. All right, so you got the rest immobilization of various forms. You can use ACE wrap. They might choose some different areas. They might use an air cast. whatever, but ice and elevate. Torn ACLs in the knee. They might have to do surgery repair for that. Yes, Erica.
Yeah.
Yes, what? You had a torn ACL?
Yeah.
Yeah. Who did that for you?
Dr. Bartman.
Bartman?
Mm-hmm.
Is that through Spectrum or Metro?
I went to Blodgett.
Blodgett. So he is sports medicine or orthopedic or? Orthopedic. So Dr. Bartman for orthopedic. I had Dr. Started with Metallic. I kept thinking of Metallica.
He's like the sports guru.
He is.
Our family has him too, for our other jobs.
Yeah. So you guys have various resources if you end up with ortho issues. So some of the meds, analgesics and or muscle relaxants. What slide is this, 10? How come I didn't talk about dislocations? Oh, we're not there yet. So, what type of analgesics do you guys think you can do for that? Or what have you been given? What kind of drugs? Ibuprofens and NSAID, right? What else? That'll help with what? Swelling too, right? What else? Erica, what did you get?
I think I got some Norco.
Well, you had surgery, right?
Yeah.
So was the Norco post-op?
Yeah.
Okay, that makes sense. What about muscle relaxants? If you're got a severe sprain. Valium is gonna relax you. It's a muscle relaxer. It's a sedator. Scalaxin. Yep. What else? Flexeril, 5 milligrams to knock me out. I can't drive with that stuff. Anybody else? Can you think of any other drugs? Anybody else have a severe strain? Okay, so those types of drugs. There you go. Nursing diagnosis. When you have, number one, I'll give you acute pain, right? Usually when you turn your ankle, man, doesn't that feel good? When you have strain or tear, man, it feels so good. Remember, what does RICE stand for? Wait a minute. Doggone, I don't have my name thing back here. How about my LA girls? One start with the A?
Red, ice,
Allison. See, I was part right. Allison. Rest, ice, compression, elevation. Also, the eye can be, immobilized too. Yep. Very good. What else? What other kind of problems do you run into? Yeah, you can't move, which is your mobility, right? You have some impaired mobility there. And if you're a marathon runner, it might be psychological and physical immobility. It could be pretty traumatic.
Self-care deficit.
Absolutely. Self-care deficit. And definitely. Good job. Risk. What happens why would you have a risk?
Well, if you're
Bedridden, okay.
Or if you're wrapped up with something.
If you're wrapped up.
Yeah.
We're not too cast yet. We're just ACE wrap. Circulation,
It's not getting
okay.
any air, so it's just going to be, you could have like the start of a pressure ulcer.
Pressure ulcer, yep. What happens with a tensor when you've had it on for a while and it kind of rolls and stuff? What is that? What happens when you rub something back and forth? That friction, so you got to watch for that. And just the sheer swelling alone can cause blistering. We'll talk a little bit about that too. Some swelling can be a big issue. I hope everybody went to the bathroom before we started. This is going to be a marathon. Okay, so we talked about these guys, right? And Mindy was right, especially with your elderly, they're not going to move very well, right? They're inhibited as it is with all the arthritis, whatnot. So onward to dislocations. We're not going to go into very, very deep depth and breadth on this topic. We're just going to skim the top, but I'm going to tell you what to look for as far as nursing, okay? Dislocation, as the definition, is loss of articulation of bone ends in the joint following severe trauma. This happens frequently in the shoulder and the ankle. You're going to assess your 5 P's, which are pain, pallor, pulse, paresthesia, paralysis. Yep, paralysis. Yep. Paresthesia and paralysis. Yep. Because what happens if you pop it out of joint and then you have a bunch of swelling?
Oh, my boyfriend does that right now.
What do you do?
Well, it was from an old injury, but he got up faster than normal and didn't feel it pop back in. And so
it was what, his knee?
His knee.
Ouch.
So now it's just super swollen, and he tried to take off like a day or two, but we got a like an ACE, not a wrap, but you know where you
Compression, like a
to keep
knee.
it in place.
Yeah.
And
Mobilizer.
he's been taking ibuprofen. He took some Vicodin right in the beginning, but now he's just doing ibuprofen and trying to stay off it, but it's not really going
So maybe
down. He
he's
tried to
gotta
ice it
check.
the first day, but he's stubborn because he's a guy, so.
That's just, but it's a guy thing. Does that go with the MIs too?
My dad's big hip comes out a lot, like sometimes I think it's
His hip just pops out. Oh
He
man.
used an artificial hip, and the ambulance has come, they like give him twilight sedation and pop him back in.
That's what the ER is for. Give him a little bit of conscious sedation and pop that shoulder or that hip back in place.
Get out to the ER. I mean, if he's got one of his hips that's popped out of place,
Might end up being an ambulance ride. Depends how big they are. So probably wouldn't hurt to have that checked out. You know, it'd be a shame to have permanent damage, and we'll talk about that because that's where healing doesn't occur because people kind of blow it off or try to take care of things on their own.
Play this Camtasia for him when I go.
There you go. So you're going to look for circulation and ligament damage like Sarah's boyfriend should do. Immobilize if necessary, ice physical therapy, educate on the pain medications because you don't want him to take Norco and Tylenol PM and then Tylenol on top of it. And I don't know what else has got Tylenol in it, but you know, they have to know what they're taking. Yes, you can take Tylenol and ibuprofen, you know, so education's very important. People think they can only take one or the other. But if they know what the drug is, they work differently. You just want to be careful and not do things like when you're starting to look at like Flexeril, Valium, and Norco. You got to start being careful there. Right? You get somebody that they get a 6-pack of Norco and they go home and they had a nice shot and a Valium and then they drink a 6-pack of beer and then they aspirate because they passed out. Subluxation is a partial dislocation where the bone ends are still partially intact. You've got pain, you've got deformity, and you've got limited motion. I think I've got some pictures on here. Somewhere. There you go. So here's a nice picture of a dislocated shoulder. I think I've got a spine in here too. Wow, anybody got a migraine? I'm sorry. So here's a sublux. Can you see? Here's your normal disc, and here is when it slips. And this one's coming down. This one's trying to come down, and this guy's moving out, and then there goes your disc. Doggone it. Yes, Sarah.
That could happen in the shoulder too, though, right? It's just not completely out.
Yeah.
Or it's just partially open.
This is totally dislocated.
Okay.
This is just a better picture when you say sublux.
Got it.
Okay. This is a really nice picture, if that's the way you study. I think I still have permission for this one from nursing education. But if they have traction, when you have a fracture, there's different things. You got to diagnose it. Usually they'll do an x-ray first. And then from there, where do you go? Okay? These are the problems, the symptoms you're going to see with a fracture. Traumas, the risk factors that you can run into that cause issues with fractures. People, that's why it's so important for women to make sure that they get their calcium before menopause, because you run into this afterwards, the osteoporosis. You can have pathological fractures from myeloma, different types of cancers, different types of metabolic diseases. These are problems you can run into when you immobilize it. You can run into issues with delayed union or non-union, where the bone doesn't come back together correctly. Angulation, you can run into infection, and that's more often with an open fracture, or once they have these pins inserted, or external fixation. Because you got stuff sticking into the bone and outside the body, right? When the inside of that bone is exposed to anything outside the body, that significantly increases your chance of infection. We'll talk a little bit about compartment syndrome when you have a lot of swelling. I think my students from 101 know exactly what that is, right, Sarah and Mindy? Yep. Venous stases, we'll talk a little bit about that you can run into. Thrombus and fat embolus is also another issue that you can run into. Does anybody not know what a fat embolus is in here? Or about fat embolism? Okay, good. Just make sure I cover that for you. I think it's in here. The different types of issues, you gotta, once you diagnose the fracture, you gotta immobilize it. You're gonna, most frequently, you'll see surgery, okay? In the case of my brother who crushed his heel, they threw a cast on him where most of the people would have had surgery on it. He has no access to health care very well, and they said, we're going to cast it, and you're a smoker and a drinker, and good luck. So he's trying to heal it on his own, and it takes like 3 times as long. And he's finally in a walking cast that I was able to get a company to donate to him. So it helps to know people. And the surgeon told him immediately, he said, once he took off the initial cast, he says, you needed the cast on today. It took me 2 weeks to track somebody down to get him one. And he got the runaround in between. The other option is if you can't cast it right away and you can't do surgery, which is an open reduction internal fixation, they might have to do an external fixator on it, or they might even put traction on it. And you're going to see this more often, traction, is if there's other things that they have to worry about, first. Is it somebody that is older than dirt that they're not sure they're going to live through surgery? Okay? They might, put them in traction. Is it somebody that's got multiple fractures or was in a multiple trauma? Okay, they might have other issues that they got to take care of first, so they're going to put them in traction, take care of that later. They've got to worry about a lacerated liver right now, or a spleen that's hemorrhaging that they got to take care of. So most times they're going to get them to surgery. Remember, here's your 5 P's. Whenever you see an initial trauma or after any intervention, this comes into play constantly. They might have manipulated something or changed something, or if you accidentally moved somebody that was in traction and the weights got ended up sitting on the floor and you had to fix it or check it, you have to very closely watch to make sure that circulation hasn't been impacted. It's important to maintain that immobilization. Yes, Sarah. Katie, God darn it.
Paresthesis, is that the tingling?
Tingling, yes. And paralysis is like, I can't move it. Okay, so you want to maintain immobilization, prevent complications of immobility. That's a concept. Prevent complications of immobility. So you think about that. Everything that could cover that umbrella, that would be under that, are things that should be starting to run through your head. What are my 5 P's? What are the other issues of that immobility? Can that person move? Can they move on their own? Are they safe to move on their own? Maybe they can move on their own, but they shouldn't be. I had my 3-year-old son. He was just learning to poop in the toilet, and he went to run to tell Daddy with his pants half down, got his foot caught under some linoleum, he twisted, popped his femur, and they put on a boot. They put on Buck's traction with tape. And the tape, when you put tape on skin and you pull on it, when you take the tape off, you take the skin with it. But they also gave him codeine, and this kid sat up in bed thinking he was at home on his own couch. And that was my opening day of nursing school. That was my first day of nursing school.
How long was he on the traction?
2 weeks.
A 3-year-old?
A 3-year-old. Yes. Yes. Of course I was cross-examined for child abuse. And of course the ER that night says to me, "Are you sure you want to bring him in the middle of the blizzard?" And I says, "Well, the leg is kind of swollen to twice its size. I think something's wrong." That was Munson. And I lived in Bel Air. Oh, fun. So here's your different classifications. Don't forget cast skin care, we'll go over that. Infections, we'll look at that. Distal, middle, proximal. Kind of good idea to know what these terms mean in relocation to the body. Is it stable or unstable? Is it simple, complex? Epiphyseal, that's like at the plate, or the growth plate. Very important to know with kids. You know, if you have a fracture at the epiphyseal plate, it might cause them trouble later on because that bone, they're still growing. Okay, so it's important to know where it's at. Where are we at? 16, fractures, okay? That's any break in the continuity of a bone. All right, occurs when the bone is subjected to more kinetic energy than the bone can absorb. We're going to talk about some classifications, and some of these might overlap a little bit. So simple is closed, where the skin's still intact, right? Very easy, easy. Green stick fractures. There's a lot of pictures in there. I think I got some pictures up here. You can Google them if you need more information, but simple is just closed, right? Compound is when that bone goes through the skin. Nasty thing to see when you're on a motorcycle and they're not wearing their leather. Or sometimes when they are wearing their leather.
Or that basketball player. That was a mess.
Missed that one. When was that?
Oh, gosh. Yeah. What was his name? I don't remember. But
They have pictures on TV?
They were.
Oh, and they showed them on.
He jumped up to shoot the ball and like came down on it wrong, and it was like down here, I think, and it was just completely open fracture.
Wow, cool.
You would love it. It was disgusting.
Poor guy. Oh, not poor guy. But anyways, so when you have this skin integrity interrupted and you got a chunk of the bone sticking out, just think when you got that integrity interrupted, you know, the significance of that. Complete means just the entire width of the bone is affected, the fractures all the way through the bone. Because when you think about hairline fractures, right, they're not all the way the width of the bone, okay, or incomplete. Comminuted means you got a bunch of little chunks, you know, it's just kind of crushed.
Would a hairline fracture be incomplete then?
Yes, hairline would be incomplete. I don't know if how much you hear that anymore. I hear it more. My daughter, she was in a karate tournament, and I was a bad mom. She was in a competition. She was done with her stuff for the day, and we were in Detroit. Got caught in a traffic jam. She goes, "Man, my thumb really hurts." And I said, "Okay, just take some ibuprofen." We iced it, elevated it. You know, it took us 3 hours to get home. That night, she goes, "You know, it's just kind of take some more ibuprofen." Woke up the next day and it was all nice and bruised.
Yeah, so it's okay.
So it was broke.
Look at his bone.
Is that the best ball?
Yeah. Can you see it?
Coming out of his knee.
Below his knee.
Holy cow! Yeah, you can pass that one around. That's really displaced. That's a good picture. Yeah, go ahead. You can pass it around. Make sure you get your phone back. So compressed is where the bone, comminuted, you can see it's just like there's pictures. There's a PowerPoint shot in there which just shows different chunks. Compressed is you'll see that it's just smashed on top of each other or sideways, and that's there's another term in there too. Compressed is kind of more like crushed. There's also one where the bone literally, when you have compression fractures, the part of the bone can be literally shoved up inside the other, and that's another term. Let's see if we got that in here.
Would they go in at that point and like try to remove some of the fragments?
Yeah, well, it depends how bad it is. And if it's something they could do, like in the case of my brother, his was crushed. He literally came down on his heel, and it was crushed into different parts, and all they did was cast it, and they're hoping that it all goes back together again. If they're going to go in and do surgery, they're going to clean it up as best they can. They're going to do, they might even do some pinning and pull out the pieces. So you can have stable versus non-displaced, or stable is non-displaced. Your alignment is maintained and they'll just cast it. All right. Versus if you have an unstable or displaced, it's out of alignment, it might override. There's going to be spasm. You need to manipulate and or have surgery. They'll need to manipulate it before they put the cast on it. You're going to see this sometimes ankle, when you have ankle fractures, it's nasty because once you get that, some are worse than others, but it just never seems to heal right. You always seem to have trouble after that. Stressor pathologic. You've got disrupted bone homeostasis and inadequate repair of the face in the face of repetitive overload. So you need to look at that. Why is that happening? My granddaughter scared me half to death when she was 1.5 years to 2 years old. She just hopped off a swing and fractured her tibia, and then 2 weeks later did the same thing to the other one. I thought for sure she had cancer. Hmm? Both legs. And then she was the one that they, U of M put the boot on, or put a cast on it, and she kept complaining of pain, and they kept telling my daughter-in-law and my son, oh, that's normal. And then she went in, they took the cast off, and she had like a dollar size pressure ulcer on the top of her foot. That is now permanent. But it was, you know, she was small, and she didn't have to have it skin grafted. It healed in. She lucked out, but it's a scar. But she was lucky that they did it sooner than later. But, you know, that they were not paying attention to the pain, and that's a huge thing that you're going to see that we're going to talk about is fractures. And the issues that you run into with healing, swelling, that you have to pay attention to that pain. So why are they getting a fracture in a long bone? Is it a spontaneous? Is it expected? Is it because they're an older person, an old lady that's got osteoporosis? Or, you know, what's going on? Do they have cancer? Is there something going on that the bone's getting very brittle? Why is that happening? So here's some nice pictures here, and this still doesn't, oh, here you go. Here's one that's impacted, where the sheer force just drives the bone right into each other. I think they've got another one where it shows it in the opposite direction. This is impacted. It literally goes into it like, you know, when you put your vacuum cleaner, the different rods together, if you're putting something together and one pipe fits inside the other, that's exactly what's happening with this one. You're shoving it in there even though it doesn't belong. This is impacted. It's a complete break. These are all, this is displaced. This is an open compound where you're going through the skin. This is a complex comminuted where you got a bunch of different pieces. Oh, this is another one. Here's impacted. See where it's shoved right up inside? Here's comminuted where you've got a bunch of, these are all just crushed. Bunch of different pieces. Green stick is incomplete. Sometimes you'll see a spiral. Was there a spiral in here somewhere? Right here. See where it kind of wraps around the bone?
What if the entire width? So would that be complete?
If it's the entire width, it's complete. This is not.
No, I'm talking about the spiral one.
If it ends up breaking and you can pull it off, yes. But if it's not necessarily. It may or may not go through the whole bone. Let's see, so you got manifestations. So you may or may not have, usually with you are going to have some soft tissue injuries, the muscle may spasms. Did I say muscle may spasms? Really?
Spams.
Were you hungry when you wrote this?
It was 2 a.m. What'd you want? Oh, Lordy. Oh, my. Think of spasm. Okay, there you go. All right, so the things that you may have to watch for, remember those 5 Ps. And you're going to see people that come in, mostly if you're lucky enough to be on 4 North, they're going to have what's called neurovascular checks that you have to do. And neurovascular, you're going to be basically checking your 5 Ps. That's it. You got any numbness or tingling? You know, is it pink? Is it warm? Does it have good cap refill? Can you get a pulse on it? Is it getting better? Is it getting worse? Do I have to check on, do I have to talk to somebody about this? You might have some obvious deformity or shortening of the extremity. If you have a hip, hip fracture, especially like in the neck or the head of the femur. It's usually shortened and externally rotated. You should be able to find pictures of that somewhere. If I don't have one in here somewhere. They might have felt a cracking or popping during when it broke. Oh, now we get into the interesting stuff. Ugh. Narella, would you toss me some tissues? Bummer. Thank you. Say again? Oh. Thanks. All right. All right. So healing phases. When you look in the book, it might be just a hair different. Sorry. You have to hear that on tape. There are kind of three to four types of phases. But you have the inflammatory or the bone injury phase when you actually have the fracture. So you're going to have bleeding at the site. Because remember, bones, they do have good blood supply. You might not see the bruising right away. You think about where is the bone. It might be deep. Remember that term, visceral? Think about the pelvis. If you have a pelvic fracture, where might you see some bleeding maybe a little bit later than earlier? Anybody? That would be some sort of kidney or bladder tear. Where would you see bruising? Maybe. Where else? So you might see bruising in the pubic area. Where else? Abdomen. So abdomen up here, down farther. You might see some like the pubic symphysis.
Upper thigh.
Upper thigh, you might. Where do you usually lay? On your back? Think about where your pelvis is. Right here. I got a big area. You better make sure that you take a peek and roll. Strip and flip. Make sure you watch for retroperitoneal type bleeding, where that bruising is not. If you have a pelvic fracture, you get a pelvic fracture, make sure you watch for that bleeding. You watch for that blood to go into a dependent area. You can lose a lot of blood in a pelvic fracture. You'll see back in the day when they come in the ER, we used to wrap a sheet around them and just tie up their pelvis. There's better ways of doing that nowadays. But when you have somebody coming in for multiple trauma, that's what you got to do. You got to take everything off. You got to look everywhere. In a pelvic fracture, when you've got a deep bone fracture, that bleeding in that tissue might not show up right away. So remember, where is the bone? How deep is it? You might have, with a fracture, it might tear a vessel. What if it tears an artery? You might end up having a huge hematoma in the groin, think about that. Where is that fracture? What is it tearing? What is it affecting? So you have that initial inflammatory phase, the tissue tears, there's bleeding, you get a hematoma, you have inflammation, you have vasodilation, yeah, some exudate maybe, but it's exudate is just drainage. But the vasodilation, that's your inflammatory response. Remember your inflammatory response. If you don't remember that, look it up. Your vessels are dilating to bring oxygen and circulation to the traumatized area, right? Because it wants to repair. It's going to bring those macrophages and your cytokines, your bradykines. And so that's where your exudate's going to start showing. And that's all I have to say about that. Your reparative phase. This is where you might see a couple different terminologies, because it goes, you have a soft callus and a hard callus. So that's where it's closer down to 3 versus 4 phases. So you've got a soft callus that forms like at 2 to 3 weeks, and a hard callus 4 to 8 weeks. So you can see here it really takes about 3 months for repair. Did I do that? I did that. That looks goofy. Sorry. I should not try to do this at 2 a.m. You have remodeling. So inflammatory, reparative, and then remodeling. That's where you end up getting that hard callus by 8 weeks, right? And then somewhere in between this 2 to 3 months with this fibrocartilaginous working, you have remodeling. It's where the new bone is starting to lay down. This starts anywhere from 8 to 12 weeks up to a year. So you remember when you take the cast off, they don't leave a cast on usually for a year, right? So just remember, when that cast does come off, that's not completely healed. It takes a while. So you've got to keep that in mind when you're thinking about running that marathon. There's more information in your book about that. Anybody ever have a cast? So when did they take off your cast?
I was young, I don't remember.
Anybody more recent?
6 weeks.
Usually about 6 weeks, yep. Mm-hmm.
I feel like it was for my ankle. I still walked around with crutches, so like a week after that, because it was still so sore.
I'll bet. So just remember that it's not healed when they take that off. So bone healing. Think about things that it's influenced by. You got age, young versus old. Did they have good nutrition, and did they take their calcium like they was told? What is their general health? Have you guys, I've talked to you about protoplasm, right? It's just the general health and what you have going into a situation. If you're not a very healthy individual and you have poor nutrition lifelong or over an extended period of time, you're not going to heal as well, right? If you're a smoker and a drinker, are you going to heal as well as somebody that's a young, healthy athlete that runs every day and eats all their proteins, carbohydrates, and fats, and what else am I missing? So there's a big difference, right? The protoplasm going into the injury or the trauma, whatever. Where did I leave off? Smoking. What does smoking inhibit? Oxygenation, oxygen to the tissues. Huge difference. What about compliance? You might have somebody that says, oh, I heard it and I just thought I'd wait and see if it would heal on its own. And it doesn't. Or they have a walking cast and the doc says, don't be on it for more than 20 minutes, and they walk 2 miles, you know. What are you going to do? So was treatment sought? Did they follow through on their treatment plan? What about if the doc fixed it right? Does that happen? You betcha. What is their physical activity before, during, and after? You know, like I said, that all in nutrition, it all impacts how well you're going to heal. The type of the fracture and the location all impacts that. What about your comorbidities? How well do you think a diabetic's going to heal compared to somebody that's very healthy and eats right and exercises regularly? Big difference, right? Or heart failure. How well does that pump circulate oxygen to the tissues on a regular basis, right? Somebody with a say a 70% ejection fraction of their heart versus 20%, big difference, right? So how many comorbidities do they have? Time for healing. That can be general. Arm and foot could be about 6 to 8 weeks. The hip might be 12 to 16 weeks. So, and it, you know, so not only does it mean, you know, there's a lot of things that can influence it. Plus, you know, did they have an intervention done versus none or partial? Did they seek treatment? Did they try to let it heal on their own? Did they opt to do, like for my brother, they opted to do conservative treatment versus surgical intervention. So that all impacts the time of healing. And then think about the issues that you run into. Hip alone, the complications you can have are location, mobility, skin, anesthesia, because they might have to go in and do some work on that. Think of the elderly. What are they like under anesthesia? They're old, they got friable skin, their organs are older, so all of that. They're not going to move as well. Trying to think if there's anything else I can think of that. What number are we on? 23? You're funny. Ain't gonna happen. So, oh good. This is new. Is this a new slide?
No, I don't have that slide.
It's on the outline, but there was no slide for it.
Okay. Now there's a slide. Yeah, I was trying to keep you guys guessing there for a while, I guess. So emergency care. You obviously try to immobilize it if you can. Think about if you're out in the field and you might have to grab something that's sitting in your trunk. You know, if somebody come up on a car accident, the kids were sleeping on pillows, grab 2 pillows, and you run up to the accident and you just immobilize it that way. You might not move it. You just want to make sure that you try and keep them, say that you might have to extract them before help comes. And you're saying, okay, your car's on fire and I either help you get out now, possibly break your neck or paralyze you, but I'm a good Samaritan, and would you rather be dead or paralyzed? That could be a toss-up, that they might hate you for later, but you're just doing a good Samaritan, right? So you're trying to help. You cannot reset something for them. You're just trying to protect something until the EMTs get there. I had a friend of mine who was in a tree blind, I think. He was doing something. Maybe he was building a thing. I don't know if he was doing a tree house for his kids or blind. I forget. People drop out of the trees a lot by me. It's usually tree blinds for hunting. It's either that face first or backwards with back injuries, crushed vertebrae. But he broke his leg. And, you know, the first thing they do is they come and run and grab me. And I say, call the EMTs. I can't do anything for him. He's got to get to the hospital. So I go there. All I can do is just hold the leg until somebody could go get me a pillow to just kind of, you know, all we did was immobilize it until they came, because I can't set it. All I can do is try and hold it and keep it still so that it doesn't hurt so much, right? There's not a whole lot I can do. I'm watching to make sure that he's still got circulation. And that's about all you can do. You might, if you have to pull somebody out and take them somewhere, you might have to grab a couple sticks and put one stick on each side of the leg and wrap it up with a belt, or rip up a shirt, you know, a sleeve, tie a sleeve around there. What do you got to do to immobilize it to get a hunter out of the woods that fell down and broke his leg? If it's an arm or something, maybe you can just strap it to the body, you know, just to immobilize it, okay, just to get him from point A to point B, and watch those 5 P's, remember? Okay. Just a lot of times you might go above and below a joint, like if they fracture something, you can, like it works really good to put a stick on both sides and wrap it above and below. And usually you'll do that above and below a break as well. Oh, there you go. Strap arm to the body. Let's see, what else? Air splints. Anybody not know what an air splint is? You have never seen an air splint? A lot of times they're just like a chunk of plastic, and it's got like a not a balloon, but you know, an inflatable chunk on the inside, and there's actually a little straw that comes out that you can inflate it and blow it up, and you put it on. It's got like a stretchy elastic and some Velcro, and they'll put that. A lot of times you'll see that for ankle sprains. They'll use that, but you can blow up the air, and it's more comfort and to keep it immobile. Okay, Google it. Let's see, what else? I walked up on a really bad accident one time coming back from, I usually worked the 8-mile race up on Mackinac Island until I started this job. And so that's like the first weekend after Labor Day. I was coming home and traffic was backed up, and I could just see big black smoke. So I pulled off to the side, and apparently what had happened was a guy fell asleep at the wheel of a truck, pickup truck, and was pulling a big, beautiful boat, and they were both in the trees. Yeah. The vehicle and the boat were in the trees, and by the time I got to it, another lady, 2 other ladies had the wife on the side of the road, right by the, you know, those silver braces, the guardrails, okay? She was laying on the ground. She had burnt hands. And this truck and boat were several hundred feet out. You know, he had gone airborne. So I don't know how she got out, or if she was just ejected or what. He was literally still, you could see his body in this truck because the tires were already on fire by that time, and all you saw was this form reaching out of a window, and it was charcoal black in the middle of all these flames. So he was just crusted, burnt alive. She was laying on the ground. She didn't know what was happening. But what I grabbed out of my trunk is my little, I have just a little kit, and all I did was, her hands were just, there was just, you know, they were like degloved almost, but they were just very badly burnt. And all I did was grab, I had just, you know, just some 4x4s and stuff, and all I was doing at that point in time was trying to cover them. So I took my 4x4s and covered them the way I had learned my burn dressings, you know, individual, keep them apart, and just wrapped them. And then once the EMTs got there, they were able to put saline on it, keep it moist, wrap it up, and keep her warm. Because all we could do was we rolled her, put something warm underneath her, and bundled her up. And I can't remember, she'd asked, like, you know, where her husband was, and we just said he's just in another area. You couldn't say anything. But you could see that for miles. Just everything was just up in flames. That whole area of that woods and stuff, and apparently he had just fallen asleep, and he just went airborne right into the trees. Say again?
Especially with carrying a boat, you had to.
Yeah,
I mean,
really.
70 miles an hour. 70 miles. I mean, that was the flow of the traffic. And you just fall asleep, and boom, off you go, off the side of the road. Yeah. Yeah. Yeah, that's a bad way to go. I think that's one of those pictures that's forever ingrained in your brain. You never lose sight of that picture. But that's what you do, is you just, if it's open, it's better to put, like, I walked up, I was driving home, and some lady was standing by the overpass by Cedar Springs, and she's going like this, and she's got blood dripping all down her arm, and I stop, and I get out, and remember, I'm 57. How old are you? Give yourself some time.
I'm 51. I've never seen it.
Maybe I'm just lucky. I'm a commuter, though. But she, well, depending on where you work, she was just dripping. She had a fistula from dialysis, and it was brand new, and it just broke loose. And she couldn't stop the bleeding. Of course, she was scared, and she was bleeding pretty good. And so I just grabbed, was it sterile? No. I grabbed a towel out of the back of her car, slapped it on there, and, you know, we tried to wave. She was waving somebody else down, and I said, I promise, I will not let go of this until somebody comes. And because she had lost quite a bit of blood already by then. And I had blood all over my arms. The other guy called 911. Did the fistula probably get trashed? Yeah. But, you know, you do what you can, okay? The best thing is to try to keep things clean as possible, because remember, especially when you got traumas and you've got open bone, open wounds, you got road crud, you've got dirt, you've got trees. It could be particulate, like from cement or gravel. All that goes inside. Just think of what a huge risk that they're at for infection. I've seen people 2-3 days, a week out from a trauma that still hadn't had glass and garbage taken out of their hair. And that's inexcusable. That's poor nursing care. There's no excuse for that. I don't care where you're at or how busy you are. There's no excuse. That's all I have to say about that. Shoot. No, I don't. I said pillows, right? Evaluate before and after splinting. Very important, right? Didn't I say that on that first part? Whenever you do a manipulation, trauma, before and after splitting, don't forget those 5 Ps. Any type of, or I even mentioned, like if you go in and somebody's in traction and you notice that the weights are up against the bed or laying on the floor, and you have to reestablish that. Number one, I probably would mention it next time I see the doc, unless I see a change in the circulation. But mention to them that, you know, you had an issue with the traction, so that they know, in case they want to get another x-ray, to make sure that they didn't pull it out of alignment. Talked about 5 P's, bleeding and preventing infection, right? I think we're done with that. Diagnostics, history of the incident and assessment. Very important, always get a history and physical. Then you think about x-rays, right? Because you want to make sure that you know what broken bones you have, if you can see them. I've seen people gone in for MVA, motor vehicle accidents. They go in, do an x-ray, looks fine, send them home, and on the way home they're getting numbness and tingling in the arm. Better go back to the hospital. Take another x-ray. Oh, you got a fractured C2 or something. Oops. Get it taken care of before you become paralyzed. Let's see, x-rays. Another reason we already talked about, cancer. Why are they having fractures? Where they're having fractures. Look at a fibula or rib fractures. If a fibula is your tibia is more bearing your weight versus your fibula. And then you want to do some labs, right? What are you thinking, Mindy? Well, it depends. This is where you're going to start. You're going to do x-ray first, especially if it's just a fracture.
They do CTs on for certain areas.
They
I
might.
got a baseball bat to the head, and they did a CT at Helen Fox right away because to make sure, because it was like no, there was nothing coming
Think
out.
about your head.
On the outside, like, it was
Remember,
just
blood
right
and
on her
bone.
eye, and it was right on her,
Yep.
right here.
Blood and bone are the same color. You want to make sure that you're not missing a subdural hematoma.
Is that what it is?
Yep, that's why they did a CT. Blood and bone are the same color, so you'll look for that. And when you get a trauma like that, I had a neighbor, I have all these, had a neighbor that was on his tractor. He got hit by a drunk guy in a pickup. That happens up by me. He was just mowing his lawn. Oh yeah, the guy that murdered his wife crossed the street. I didn't find out till 6 months later. I'm on county line. Anyways, he was just mowing his lawn. The guy, he really got plowed into. He got thrown. And he was complaining of headaches. Kept going to a hospital that I wouldn't take a dead dog to. Out in the middle of nowhere up there. And it's not Mecosta. But he kept having these headaches. And they did other bad things to him there too, but he kept complaining of headaches ongoing for like 3 months. Finally, you know, I said he needs to see a neurologist because they called me up and said, why is he having these headaches? He had a chronic subdural from that accident. And by the time we got him in for a CAT scan, he almost herniated his brain. So he was starting to get confused that morning. That was 20-some years ago. But that you can get chronic or acute. Chronics can be like 3 months down the line, where it's a slow bleed. It's usually a venous type bleed versus arterial bleed. Arterial bleeds are more epidural hematomas. So anyways, look at what types of lab tests you might have to follow. What if it's somebody that gets a broken bone and they're got a factor deficiency, factor 7 or 8, hemophiliacs. What if, or even if they get a bruise or a hematoma, what does that impact? What if it's somebody that's on Coumadin? What other type of things are you going to want to check here? Right? What other kind of labs? So think about that. You know, PT, PTT, yes?
Yeah, I was going to ask the same thing. I think what is
Mets, metastasis, bone Mets from, not the, is it New York Mets? Tigers should have won. But really, what other type of labs do you have to consider here? Think about that. So medications. Pay attention to that pain. Very, very important. This is very important. Are they going to have a lot of pain? Yes. But gradually that pain should get lessened and should improve. It should not get worse again. Take for advantage my granddaughter. She had that cast on. She was having pain. She's darn lucky that she was just having issues with a pressure ulcer versus actual circulation issues. All right? We'll talk about that in a minute. Sorry. I need some hand sanitizer. Okay. I got it. Let's see. We'll talk a little bit more about pain. But the issue is that pain is a symptom of circulation, right? Think about when you have somebody that has chest pain with a heart attack, right? What does that mean? Lack of oxygen to the heart muscle, right? You're having a heart attack. Same thing here, all right? You're having lack of circulation if that pain's acute or increasing for some reason. Something's happening to the circulation in that area. Christian, stay with me here, bud. So it's important, ice, elevate, compression. If you got too much compression, alleviate it. We'll talk about compartment syndrome and what you have to do with that. NSAIDs. You have to be careful with NSAIDs and fractures because sometimes orthopedic surgeons will say it interferes with the healing process, so I don't want to give it. There's a higher chance of them bleeding. I don't want to give it. I'll tell you with my open heart surgery, when they do a sternotomy, slice the sternum in half, that's the best thing since sliced bread is Toradol. Toradol is industrial strength ibuprofen. It's a massive amount of anti-inflammatory. Works great, better than any narcotic, but I got to watch for bleeding and I got to watch that person's kidneys because it's an NSAID that definitely impacts the kidneys. So you got to, weigh your pros and cons. What does that doctor want? What can I give? If it's an 80-year-old lady, I'm probably going to kind of shy away from it. If it's somebody with a creatinine above 1, I'm probably going to shy away from it. Or if you're worried about bleeding. If you got an open fracture, you're definitely going to have antibiotics, right? What, can you think of other stuff that you need for somebody that's fractures that's not moving around a whole lot? Stool softeners, yep. What about if it's somebody that's not moving around like they are at home? Blood thinners, right? Lovenox, sub-Q heparin. Smaller dosing, right? Just enough to keep them from getting a blood clot, right?
calcium?
Yep, calcium, vitamin D, multivitamins. If it's a drinker, you might have to start thinking about that folic acid. multivitamins. They might get a banana bag. And think about if you've got a fracture and your bone is pulled out of place, what are your muscles trying to do? They're trying to get it back into place, right? Right? A lot of spasming. Very uncomfortable. So any spasmodics? Multivitamin. So this is the types of treatments you're going to see. Open reduction. This is an external fixator. What happened here is you can see where the fracture is right here. So they got pins above and pins below to stabilize it. So it's going straight into the bone.
I wonder what happened to the skin.
Right here, what happened is it probably got tore off. Yeah, it could definitely be road rash. What this is here, this is a graft. And what they did was they probably took this off of his hip or the thigh, and then they run it through a mesher, you know, like a cheese grate, or you know, those things that roll, pasta thing. And what it does is it puts a little holes in it, so it stretches out the tissue more. So it gets all these little holes in it, like a mesh. And then they lay it on here and they either suture it or staple it. And then it heals. Each of these little holes will heal in from the side. But you got to have healthy granulation tissue underneath that. See that red hamburger look? That's what you got to have so that those vessels will connect to the tissue. Yes?
In my last class, I got an OR day.
You got an OR day? Okay.
We had a guy that had burned from the shoulders to, like on his back, from the shoulders to his knees. And I watched them, they scrape off everything. And then they took some of his skin from his calf. But then the rest of the skin was like the manufactured, it's frozen. You just take it and thaw it out in warm water and they stretch it out. But they're not as neat as I thought you would be when you're, like when they staple it, they were just stapling all over his entire back, just slapping him in.
Well, with the manufactured skin like that, that's only temporary.
Yeah.
This was done relatively soon after his burns, correct?
Yeah.
Just as like to protect it, almost.
Yep. Where we used to wait and let them get infected, and then they turn orange and green and brown, rust color. So, yep. So nowadays, compared to when I used to work burns, they'll go in and they debride the area right away. They get it looking all like this, nice red beefy. And then they throw on, if they've got, they use whatever skin they can get from you, and they'll put it on. That's what this is. This is a permanent graft. This is a person's own graft. The other is manufactured. A lot of that stuff is more temporary, or cadaver. They can grow your own cells too, but that takes a little bit of time. But what they want to do is they want to get the garbage off, clean it up, and get this going and primed for taking permanent tissue as soon as it can. So a lot of times they'll cover it even with temporary. We've even used pig skin in the past where you could see the patches of color with the spots, the polka dots. Yeah. But anyways, that's what this does, and it heals in from the side. So they can do this all at the same time. So this guy might have been in traction first, but they try and get you in OR like within 6 hours if they can to start getting work done on those fractures so it can heal. Less chance for infection long term. So and remember, when you do this, you got to watch nerves, blood vessels, right?
How long would that external fixation stay in for?
I think it depends on what the goal is, what they need to do. It's not long term. I've seen some of them stay in a long time, but I don't think it is as long anymore.
So would you go home with something like that?
I've seen people that had to wait. And you have to be very careful because that's a high risk. That pin is outside the body. If you don't keep that clean, holy cow, you get an infection in the bone, you got osteomyelitis. That's a lifelong struggle. Because once you get an infection in the bone, you end up having to have IV antibiotics. A lot of times you end up with a PICC line or a Hickman catheter, months and months of antibiotics, or at least weeks. And it seems like once you get an osteomyelitis or infection in the bone, it's something that haunts you for the rest of your life. So it's just, this is not meant to be permanent.
But that's the same thing as like a halo, kind of, isn't it?
Can be,
Type of
yeah.
device.
Halo's got the pins that's going into your bone. And you don't see that as often either. They try to get that fixed as soon as they can, as long as the person can tolerate it. But you might see people, you don't see them as often as 20 years ago or even 10 years ago. So here's where you have the internal fixation. Okay, so you get the stuff in alignment, and you've got the pins, you've got a plate that they throw in here, and here's the screws. And a lot of the times you'll see this stuff, that can be permanent. Sometimes if they put a rod, like in a femur, they can take that out if you're younger and healthier. But if it's an older person, they're more apt to leave that type of stuff in. This is permanent. This is for, can you see where this fracture is right here in the neck?
Oh, yeah.
But here's your plate, screws, nice big old chunk. Shove it right in there. So you need that hardware.
It's probably on bones that get a lot of movement, so you really...
You gotta stabilize it. Yep. Here's a nice picture. See that video on how to use a hip abductor pillow, because you gotta maintain the alignment of that hip. Something important to be aware of. Just saying. Don't forget with these types of things, make sure you know what that's made out of, what type of material they're using. Think about future MRIs. Is it something that they can go into, or is something they have to avoid? Okay. I can't remember what our sternal wires are made of. I don't know if it's titanium, I don't remember. Onward to traction. Well, we got some talking to do here. So, traction is the application of strengthening or pulling force to maintain or return fractured bones to the normal alignment and prevent muscle spasm. If you can get those bones to meet back together the way they're supposed to be, you'll have less spasming. Because what's happening is those muscles are just trying to get alignment back the way it's supposed to be. And it's actually not as uncomfortable as you would think. If you can get it done correctly, it's actually much more comfortable rather than trying to feel those muscles spasming, trying to get them back there. So think about if you've got somebody in traction, what type of issues do you have? Immobility is a huge one, because you've got, if you can't move, what do you have to worry about? Pressure ulcer is huge. Yep. So that's why if they can, they try to avoid traction for a long period of time, just because of the immobility skin issue, and they want to they try to fix it. So the types of tractions you might see are the straight or the skin. Like I said, usually you're not going to see more than 5 pounds on this type. Back in the day, they used to use tape, which if you did your dressings, everybody see that foam tape, that kind of stretchy stuff? Did anybody see that or not see it? If you see foam tape, make sure that when you use it, you don't pull it too tight, Because even if you put it on for 24 hours, say on a chest tube dressing or on a big occlusive abdominal dressing, when you pull it off the next day, if you pulled it too tight, you're going to pull that skin with it. Makes an automatic second-degree burn or a blister because you're going to take the top layer of skin with it. So this type, they'll usually, nowadays, they have like a boot with Velcro that goes on the extremity, and that boot has a nice chunk, nice wide piece of I do? Okay. I was going to say, there's, anyways, that is hooked up to the traction. And it's the structure itself on your extremity that's pulling, not actual tape adhering. What else? Oh, balance suspension or skeletal. Skeletal is where you've got the part of the traction is actually in the bone itself. It's pulling on the bone. There's a pin going through the bone. It is hooked up to a device, rope, traction. Okay? Balanced, all balanced means that there's more than one pulling force. Because if you've got like on a hip or something to where you need to have equal traction pulled at maybe like a 45-degree angle, or I don't think I've seen 90. I've seen 45, to where you need to have it, you know, two different angles pulled out, and you'll have on a certain area of the body to maintain proper alignment through this area. You got to pull it at two different angles, and then you'll have traction from those areas. See, that's your bed. I think there's some pictures in there somewhere. Okay. So make sure that you can definitely see that you can have more weight for traction on that, because that's more stable. That pin is actually through the bone, and you know exactly where it is, and you just got to make sure that they are free hanging. What, Mindy?
What would that be most common? In what bone fracture? Or what?
Usually bigger, like femur, hip, pelvis.
Thank you.
Just depends what type, and how bad the break is. Remember, you've got to have those weights to maintain appropriate traction, right? You might see this more maybe on upper extremity. But this is where you're going to have a pin in there if you need more traction to maintain alignment. Never remove a traction weight without a physician order. You do not discontinue a weight just because it's convenient for you. Usually if you're moving somebody, you've got, if it's skeletal, you've got somebody maintaining neck. And if you're moving somebody or turning, that person at the head is the one making the call. So you maintain body alignment. Somebody's babysitting. If there's traction on the lower extremity, somebody's babysitting that very closely to make sure it doesn't whack up against the bed. If you're pulling somebody up in bed, somebody's babysitting the weights to make sure they go with you when they move up, so that you can maintain that traction at all times. Yep, here's a nice picture. This is a buck. See where that nice tissue, I don't know what type of, it's like cotton, I think, like a cotton band that runs down here. And this is like a Velcro strap, and this is foam, like a foam boot. So it's pulling the extremity, but this is what's hooked up to the traction. It's not any tension directly on the skin. Does that make sense? Okay. Here's a little bit of, you got a little bit of both. But this is just, they got this wrapped and they've got traction. They said this one's skin. This one's skeletal, you got the pin going right through the bone. So you can put a heavier weight on here than you can on here.
At least for like when the bones are just, I mean, why would they choose to do this other than surgery and?
Could be, depends on the person. Maybe they're poor protoplasm and they won't tolerate the surgery. Maybe they've got hemorrhaging or they're watching the spleen. They're unstable hemodynamically and won't tolerate it. Okay? Lacerated liver. Muscle spasm. She had it for muscle spasm. The bucks traction.
She went for hip surgery later than they thought.
Yep. So you're gonna even if they throw it in traction, it's more short term. Okay. Yes, Sarah.
Is the one in the bone forces mean one is in the like the pin, the other is the weight, or is it that you have a pin and it's pulling in two different weights?
Balanced traction is just pulling in two different forces. You see that more often with skeletal traction.
Meaning the pin is one of them and the weight is
No, there's also a weight on the pin. Balanced traction is just in two different directions.
Okay.
You can have it, here's a couple different types of tractions here. This is just one traction right here. This shows you the pin that goes through the bone. Go back. Nope, that's not the one I want. Yeah. There we go. Right. Where's the, I had one other one I thought. The ortho bed showed too? I had it here somewhere. There, okay. So you've got two different weights set up here. So you've got one at the top, and you've got one right here. So you've got it pulling in two different directions here.
You got one behind your head. You see that pulling,
Oh. Pearson attachment. This looks like this might be, this one almost looks like a boot. But balanced attraction, you've got one going up in this direction, you got one going up. I rarely see it more than, it's usually averaging on a 45-degree angle. But you're just pulling it, trying to keep it stable. That's all. That's all it's doing. That's what balanced means. Because you can have that, where is that one with the arm?
back two more.
Doggone it. Anyways, well, the arm had a balance too. You had it going in two different directions. But skeletal traction is just that. It's just in the skeletal area, right? If that'll help you remember. I see more often balance suspension used with skeletal traction, just because of where it's located. Usually in your hip, because you're trying to keep the joint or the area like the pelvis or the head of the femur. You're trying to keep that area. You want to keep it straight, and you don't want it to like sublux or move below. That's sometimes you got to hit it at two different angles to keep it stable.
Two different angles to make it balanced.
Balance, yes. It's balance. They're both, every line of traction has its own weight. So, care of a client with traction, think of the word traction. Temperature, the extremity, is it hot or cold? If it's too hot or too cold, you got a problem, right? Too cold is circulation, too hot is maybe infection, right? Are those ropes hanging freely? Are they sitting on the ground or are they laying on the bed? Neither one is good. Even if it's laying up against the edge of the bed, it's not good. They need to be literally totally free, hanging off the side of the bed. Boy, is this lousy. Okay? They have to be totally free of the bed. They cannot be hanging on the floor. They have to be off the floor. Say again?
Touching each other.
Say again?
Or even touching each other. if they're-
No. They have to be totally free hanging. Okay? Alignment. Okay? A. They got to be totally aligned. Otherwise, you're going to have trouble every time those ropes move or are not doing their job. You have to check alignment. Don't forget C for your 5 P's. T for type and location of the fracture. Is it something where you're going to have to maintain that 45-degree angle, and then you got to move somebody up in bed, so you've got to have somebody watching both sets of weights. Increase that fluid intake. They're going to need, their body's probably going to be in a hypermetabolic state. So you're going to need more calories. You're going to have it well hydrated. So you have good circulation. You got to make sure you got enough fluid and hemoglobin so you can get that oxygen to the tissues. Overhead trapeze so that they can actually help you if they can would be nice. And N for no weights on the bed or the floor.
What is it like to really take care of a patient that has like that?
Well, you got to work on 2-cell.
Very immobile and you're thinking about eating, repositioning,
Eat.
toileting. It's like-
Toileting is a huge thing, especially for a guy in his midlife that starts getting a little bit of BPH and really wants to stand up to pee. Doggone it, that's kind of hard. Or think about somebody, they're getting narcotics, they might have gone, multiple trauma, had some surgery, so they're immobile as it is, they're in traction, you're giving them narcotics, they had anesthesia, they're immobile, and they don't want to poop on a bedpan. Talk about a setup for impaction.
In those kinds of situations, like with the patients like that, the nurses have like less people, or do they have where you can tag team it a little because you need some doubles?
Tag team is a good term. Well, that's where you have to look at patient acuity, and hopefully you have a good manager on that floor, because she needs to support her staff. She needs to make sure that she's got enough upper body weight floating around to help with turns, with the care. A lot of times the RNs are more looking at larger grouping of patients that they're responsible for, and that's where you're going to see, or in extended care facilities, PN's the same thing. You're going to be responsible for a larger population of patients, and you're going to have to know what are the circulation issues that I got to watch for on these patients, the immobility, the skin. I got to make sure that I got enough tech aid help to make sure that those patients are turned every 2 hours, that they get I'm going to give them their drugs, that they're getting the appropriate hydration. So every time I walk by that room, who's responsible for those hourly checks walking through? Do you need another cup of water? Can you reach your cup of water? Do I have to give you the cup of water to take a sip? Are they adequately hydrated? You need to have that support staff there to help you so that you can monitor the labs, make sure that they got their proper nutrition. What's their albumin and protein doing today? What's their hemoglobin doing today? You got to have the appropriate support staff. You can't do it all. And if you're not getting that kind of help, something's going to happen. They're going to start having skin breakdown, which means JACO's going to get on your hospital's butt saying, you got a skin problem, Medicare insurance ain't going to pay for this, your facility's going to pay for this. Facility's not happy, so they're going to come down on that manager from upper administration saying, why is this happening on your unit? So they're held accountable eventually. So you can't keep firing the pawns for not doing the turns if they don't have the time to do it. eventually the manager is going to get fired. And then the facility gets pinged with fines. Okay? So there's accountability in place there. People have to have support. And that's where it comes into my soapbox about you are your patient's advocate and also an advocate for your profession. If you are turned over quicker because you got back injuries because you don't have enough help with your turns, you can burn them out and turn them over quickly, but is it being done too fast? Are the patients put at risk? Advocate for your profession. That means get into the government. We got 2 bills in the House and the Senate that are giving nurse practitioners prescriptive ability and allowing us to work at the extent of our degree. So that is an example of advocating for your profession. So make sure, bottom line, safe patient care. Okay? That's all I have to say about that. Mom, come pick me up. It's time for me to take my drugs. Okay, where did we leave off here? So here you go. There's the pins. Onward, casting. I got your body for 20 more minutes. Rigid device applied to immobilize bones and promote healing. Extends above and below the fracture. It's got to be relatively stable, right, in order to put a cast on it. The types that you're involved in, you should have covered these a little bit in your labs. You got a plaster. You don't see these as often anymore. You see more of the fiberglass. The plaster takes about 48 hours to dry. Total hardness, 72 hours. They'll usually throw a stockinette over the skin and then use that plaster that they put in that gauzy material, wrap it up, and then it hardens. So you can't get that wet. It will disintegrate. Fiberglass is for non-displaced fractures in the ER. It'll harden quicker. That's those nice colors that they'll throw on, purple and pink and all that. It's very important. You have to teach them what can they do with these types of casts. What do you have to watch for? You can't get the fiberglass wet at all. Even the plaster, you can't get wet at all. The fiberglass, you've really got to be careful. You don't want that wet because it's going to stink. You know, they'll get you a bag to throw over it, duct tape. I don't know. They'll put some tape around it if you got to shower or hold it out. You got to really protect it, baby it. You got to watch the skin. You got to watch for swelling. Your 5 P's. Elevate it above the level of the heart. Watch for the circulation. All these things you have to tell them before they go home so that they know when to call. There's increasing pain. Maybe we have to do something about that. I don't know if I put this in. The complications you can run into, one of the things my students should know this from 101, compartment syndrome, right? That cast is too tight and you're having that swelling, that inflammatory phase going on. That's putting pressure on that tissue. That's putting pressure on your nerves, on your arteries, trying to get circulation to the tissue. You have more and more swelling. You end up cutting off circulation to that tissue. When you cut off circulation to the tissue, what happens? It dies. As that tissue is starting to die because it's not getting circulation, it's saying, ouch. So pay attention to that pain. And it's just increasing. It's intense. If they have compartment syndrome and that cast is on and that tissue has nowhere to swell to, it's going to swell in. And that's where you're going to cut off your circulation. So they need to come back to the ER, have that cast bivalve. You've got to slice it in half, maybe just cut it off, leave the top part of it off and wrap it with tensor and keep it in a stable alignment until that swelling goes down. If that doesn't do it, in order to prevent ischemia, what they'll do, if somebody has compartment syndrome, they can get that from anything. You can get it from a DVT/VTE. You can get it from trauma in that inflammatory phase, even without a cast. I've seen it in my open heart patients where they take the vessels out of the legs and they sheared that tissue too much as they were dissecting out the vein, and then it just gets really taut, tight, gets really pale. The distal to the injury, it gets very pale. You lose calf refill, you lose the pulse because their circulation's been compromised, but it gets real taut, cold. Remember your 5 Ps. That's what you're watching for. They'll go and they'll stick a little pressure gauge in there. If it's too high, you slice it right open through the fascia. Both sides of the calf, boom, right down. If it's on an arm, they're going to slice it on both sides. If it's a torso, burns. When you have somebody that's burned, if their whole torso is burned and you have third-degree burns and it's like shoe leather and there's nowhere for that tissue to expand and swell, you have to slice them down. Sometimes might be sliced here too, here. You got to slice down through the fascia as far as you got to go, but it's usually through the fascia. That's why it's called a fasciotomy. Pop it open, allow that tissue to breathe. Allow that artery to get circulation to that tissue, okay? You're going to see compartment syndrome from a fracture or within a cast, usually 24 to 48 hours after it. But you're going to see these issues with one of your 5 Ps, one or all, eventually all. But you need to call. That's an emergency. It will not tolerate no circulation. Think about heart attack or stroke. You cut off circulation, you only have so much time before you kill that tissue. You'll see cast bivalving on 1326. Fasciotomy is cutting into that tissue to open up to allow circulation. I think there's also a video up there for you. There's nice video you can watch. And cast removal. Hang on there. Cast removal. Let me make sure I didn't miss anything out of here. I just want to make sure. Think about it. Sarah, tell me what you would do.
I would go shopping.
Let me pick somebody else. Miss Potman. Tell me, if you walked into a patient's room and they said, "Oh, my arm is killing me," and they got a cast, and just say, "I'm laying on the bed and I'm just like so, oh great." Okay. All right, this is the side of my bed. This is where my hip is, okay? And I'm laying just like this. And my fingers are looking kind of bluish. And I said, "It's just killing me." Well, what's the first thing you do?
5 Ps.
Okay, so it's pink. It's not pink, it's kind of bluish. My calf refill is kind of like, you press it and you're counting to 5 and it's still pretty pale looking. And they're kind of cool. What are you going to do?
Take the cast off.
You are? Without a physician's order. What else could you do? What would you do right there standing at the side of the bed?
Elevate.
Elevate. Good. How far?
Above the heart.
Above the level of the heart. Very good. Then what are you going to do? Let's say, does that feel any better? No. What does it look like? It hurts like heck. Now what are you going to do?
Ice.
Okay. I got it elevated. It's not getting any better. 2 minutes goes by. There's no change. And it's turning blue. What are you going to do?
Call.
Yes. I mean, you think about, what can I do right here, right now? And my arm is in a dependent position. The same thing with anything else. You walk into the room or you're out at the monitor, you hear it going beep, 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 I got a flat line. You walk in the room, you're not going to pound on the patient's chest, right? Check the patient. What can I do here right by the bedside right now to help that patient? And then what's my next move? What can I do here right now? Even if they're complaining of pain, you might need to get them. Pain's always important. We always need to act promptly, right? But what am I going to do when I have a limb compromised? What are the things that I'm going to do to address that issue right here, right now? And I might be putting that up on a pillow, and if it's turning blue pretty quick, I might be on the phone at the same time. But what can you do under your license? No, I cannot take off that cast. But what can I do in the meantime? Maybe it does need to come off. But what can I do in the meantime while I'm getting help? Okay, what can I do under my license? I think I gave you guys that example of when I had that baby that had walked into the room, the IV was sub-Q, the hand was blue. I didn't tell you that one. Oh. Well, that was in the ER. Yes, I stopped the infusion, elevated the limb, went and got the doc. She was right there. I didn't have to call her. But that had to be addressed immediately. Okay? But I was in the room. What can I do? Same thing if somebody's choking. You're not going to walk away from calling for help, are you? You know, what can you do right then and there to help them? Or if somebody's not breathing, you're not going to run out of the room. You're going to scream for help, right? You know, do your ABCs. But check the patient. What can I do to help this patient right here, right now? Does that make sense? Okay. I'm not sure how I got on that or why. But that's very important. And you might have to bivalve the cast. You might have to do a fasciotomy, but that's not quite under your license. You need to have an order for that. And somebody else is usually doing it. Oh, usually if you do a fasciotomy, usually what you're going to do is a sterile packing most times, which is sterile saline and gauze. And you just pack that daily until the swelling goes down, and then they'll just suture it up as long as you've done a good job of keeping it clean, right? And I'm going to do fat embolism, and then we'll call it good. Page 1311. Oh, there you go. Definition: fat globules from the bone marrow lodging in the pulmonary capillaries. Not a good thing. Yes, Mindy?
Would this cause aplastic anemia?
Fat embolism causing aplastic.
Well, if fat is in the bone marrow.
This is just mobilizing.
Okay, so
'Cause
if you had that, wouldn't have
why
anything
it
to
would
do with
cause
your-
not. I don't see the connection.
Okay, so if you broke your femur, and that's where red blood cells are made, and it's filling with fat.
What's happening is you're mobilizing fat.
So fat's not.
They're just globs that form. The problem is it happens when you break a big bone. They're mobilized. They are mobilized, and what you have to watch for is that they're mobilized to small capillaries in your heart or usually in your lung is where they go. All it is mobilization of those fats. They're normally in there. If you break it and they start mobilizing, they just start getting out into the free circulation.
Oh, so they're leaving the bone.
Yes.
Coming in, okay.
No.
Thank you.
They're coming from
Okay.
the bone because it's broke,
Okay.
like a big bone. Hence big fat chunks. Unfortunately, the only way to find out somebody that dies from a PE, from a fat embolus, the only way to find out is on autopsy. So you don't know when you have multiple little emboli going out and somebody comes in and arrests, you usually can't tell for sure. Because it could have been from, especially when you're looking at young males, they're at higher risks for VTEs like that anyways. But it's pulmonary emboli. But men more than women young are open to this because their bones are bigger usually from fat emboli. It's usually a femur fracture. So you have fat globules from the bone that lodge in the pulmonary capillaries. Therefore, you cut off your oxygen. Like I said, femur, pelvis, humerus can also be, and it's usually within 24 hours of the fracture. Your symptoms, you can see neurologic dysfunction, which will be your confusion and restlessness. You've got decreased oxygen to the brain. You've got pulmonary insufficiency, so you're going to have dyspnea or shortness of breath and cyanosis, where that bluish look around the lips. You'll have a petechial rash, and what I've seen before is you have these little petechiae or little pinprick bruising all over the torso, the top of the chest. And that's due to endothelial damage of the skin, capillaries. You can see it on the chest, axilla, upper arms. You might even see it in the mouth. It can happen within few hours to days, up to a week after the injury, and or post-manipulation. So remember, when they go in and have that work done, you know, if they're in traction for a little bit and then they go in and fix it because they had to do liver surgery or a resection of the lung, or maybe they tore the aorta and had to fix that because they were lucky enough to be outside the ER when it happened, that they could do that and save their lives. They're not going to worry about that leg as quickly as they are about the aorta, right? So then they had to go in and manipulate it later, so you're going to watch for it later down the line. But that petechiae, it's very distinguishing. You're going to see it and you're going to say, oh God, what was that for? Oh, this is a trauma patient. Holy cow, that really does happen. But it's very distinct. You can end up having problems with ARDS, or adult respiratory distress syndrome. And that's where you have free fatty acids. They damage that alveolar capillary membrane where the exchange of the oxygen happens. So you end up having the fluid from the capillaries getting into the alveoli lining. You don't want that, right? It's going to cause that swelling. Pulmonary edema is where that comes from, because your capillaries are leaking and it's going into your alveoli. You've got impaired surfactant production, or that part that slides the lining of your lungs so that you can expand and contract your lungs. Atelectasis is a collapsing of those alveoli because you're not having the oxygen to keep them open. They're full of junk. So then you have respiratory insufficiency. Those fat droplets also activate your clotting cascade. And then you use up your platelets. Because once you start that clotting cascade, there's only so much available at any one time, right? So once you use up all those clotting factors, then you don't have anything left to clot, and then you start bleeding, which then you end up with disseminated intravascular coagulation, or DIC. And you'll see this again, especially if you're in the RN population. Most of you want to know why. This is why. Prevention, stabilize the fracture. Because if they get a fat embolus, 70 to 90% mortality rate, high mortality rate. 70 to 90% mortality rate. And that's all I have to say about that. Should we call it a day?
Back here a second.